Webinar series was developed by the Colorado Older Adults Fall Prevention Coalition in conjunction with our team, and we represent hospitals, public health, and other organizations. The team's mission is to reduce the risk of falls through education, raising awareness, advocacy, and improving access to resources. The role of the team is to provide leadership and guidance for local falls prevention efforts. The speakers for today's webinar will be Tracy Holmberg. She is a registered nurse and is the Injury Prevention Coordinator for Swedish Medical Center in Englewood, Colorado. She was a critical care nurse for over 10 years and a paramedic before she became a nurse. Tracy has dual Bachelor of Science degrees in nursing and in kinesiology and is a child passenger safety technician and instructor. She is also a member of the Fall Prevention Network, Colorado Older Adults Falls Coalition, Safe Kids Denver Metro, Think First Denver Metro, and Safe Routes to School. Our second speaker will be Sally Thorson. She is an Injury Prevention Coordinator for the Colorado Department of Public Health and Environment. She is currently coordinating a CDC-funded project to bring evidence-based programs to a target area of Adams and Arapahoe counties. And our final speaker today will be Kimberly Watkins. She is the Falls Prevention Project Coordinator at Tri-County Health Department in the Denver metro area. Previously, she led a community collaborative to develop the Fall Prevention Network, an informative and referral resource for older adults in the Denver area. She is currently working on an initiative to improve fall screening, assessment, treatment, and referral in the primary care setting. Kimberly has a BS degree in exercise science with a health promotion concentration and is a certified project management professional. Okay, Tracy, you may start your presentation.
Good afternoon, everyone. Today we are going to, excuse me. Bear with me, I'm trying to get back to the main screen here. There we go. Thank you for your patience. Today we're going to talk about educational programs for the older adults, their caregivers, and healthcare providers. The objectives is understanding the risk factors for falls among older adults, prevention strategies for older adults, caregivers, and healthcare providers, and then we'd like to provide you some resources for older adult education. One of the building blocks that we're going to discuss today for effective community-based fall prevention programs is education. Education, we're going to discuss education about falls, risk factors, and prevention strategies for older adults, caregivers, and healthcare providers. And then if you look below that, that's the other building blocks that we're going to touch upon in the webinars coming up in the next several weeks. Exercises, we'll talk about the different kinds to improve mobility, strength, and balance, medication and review, vision assessment, and also home safety assessments and what people can do to make their homes safer. So what are some possible causes of falls? Well, it's a myth that falls are a natural part of aging. They don't just happen, and people don't fall just because they get older. Often, more than one underlying cause or risk factor is involved. So what is a risk factor? A risk factor is something that increases a person's risk, and it can be medical problems, diseases, a bunch of characteristics, and this slide here kind of shows you all the different things that can put you at risk for a fall. So environmental hazards, that can mean maybe ice outside, or it could be maybe you've got pets that are tripping hazards at your house, or clutter around your home, or maybe poor lighting for going downstairs. Also, gait and balance impairments. Older adults who have poor balance or difficulty walking are more likely than others to fall. These problems may be linked to a lack of exercise or maybe to a neurological cause such as arthritis or other medications, conditions, and treatments. What about cognitive impairments? Well, that can affect somebody. Maybe they forget and take too much medication. That puts them at a risk to fall. Or they forget that there's stairs that go down to the basement. Also, what about chronic health conditions? People with arthritis, stroke, that's already putting them at a risk to fall immediately. Medication side effects. Some medications can increase a person's risk of falling because they cause side effects like dizziness or confusion. The health problems for which the person takes the medications may also contribute to the risk of falls. The more medications you take, the more likely you're to fall. People who take 4 or more prescription drugs have a greater risk of falling than people who take fewer drugs. And that also can have side effects for blood pressure. And if people are getting up too fast or they're on blood pressure medications that cause their blood pressure to fall, that can make them dizzy and put them at a risk. Muscle weakness as well, and impaired vision. So if you've got some impaired vision, you might not see the step that's going down or a little crack in the sidewalk. So all these put us at a risk to fall. Risk factors are additive. So the more risk factors you have, the greater chance of falling. So as you can see on this chart, if you have no risk factors, you're already at an 8% chance to fall. And then each one adds up. And then if you've got 4 more risks, then you're at almost 80% chance of fall. So that puts you at a very high risk, but there are things you can do. So what we want to talk today about is education programs. And what they found is education alone has not proven to effectively reduce falls. A lot of people are in denial about falling. They don't think it's going to happen to them. It's not preventable. But what studies have shown is if you pair it with another effective building block, such as exercise, getting your vision checked, that does increase people's ability to take education seriously and to decrease the fall rate in the high-risk populations, such as those greater than 65 years of age. So how do we prevent falls? Well, we're going to touch on all of these in each of our webinars coming up, but what we can do as when we're teaching older adults and their caregivers is to stress, begin a regular exercise program that includes balance and strength. Have your vision checked annually. Have your healthcare provider review your medications and make your home safer. So what can we do to make education effective? Well, we want to deliver by trained healthcare providers. So who are these trained professionals? Well, there can be healthcare professionals, public health professionals, senior service providers, or even emergency medical service professionals. So it's somebody just trained in providing this education to prevent falls. We also want education to include problem solving and goal setting. We want them to take a role in their risk to not fall. So we want them to critically think and come up with solutions to what they can do maybe around their house, or what they can do to make their, what kind of programs they want to sit through. Length of the session is dependent on an older adult. You don't want a super long session, maybe time of day. It just depends on if there's any cognitive problems or what their lifestyle is. Sometimes we decide to do them in the mornings because they're more awake and active. Group versus individual sessions, something to take in consideration. We'll talk about this in just a minute. And the most effective when offered on an ongoing basis. So we want to be repetitive and get the messages across. Individual sessions may work better for hearing and visual impaired people. What about people with special needs or limited attention span or cognitive ability? So if you put these people in a group class, it might take away from what the group has experienced, and they might need some one-on-one education. Group is very effective for older adults especially because it provides social interactions and sharing of personal experiences and their life stories. It helps reduce anxiety and it increases motivation to adopt new behaviors. But also you can get a lot more people taught at one time than doing an individual session. So what are some principles of adult learning? Well, learning needs to be applicable to real life. These people have life experiences, life stories. You need to let them kind of figure out how it's going to make their life better. You need to capitalize on their experience. Readiness to learn is huge. If they are not ready to learn, they're not going to, the class and education is not going to be effective. Most of the time, a lot of these people have already had a fall, so the readiness is better, but we still need them to be taking an active part in their education. Use a variety of teaching methods, and Sally will touch base on that. The learning environment should be informal. And of course, adults want guidance, not grades. They're way past that stage. So there's 2 examples of evidence-based programs that we are working on right now here in Colorado, and they take all of those principles of adult learning and they've incorporated them into these programs. The first one, called Stepping On, targets 60 plus, independent, active, cognitively intact adults who have fallen or have a risk of falling or a fear of falling. And the goals of this program is to offer strategies and exercises to reduce falls and increase self-confidence in making decisions and behavioral change in situations where older adults are at risk for falling. So some of the content of the program is what it basically addresses is multiple fall risk factors. So it's not just education, but it's taking exercise, because we're teaching them how to do exercises every class. And we're telling them how to, we're not telling them, actually facilitating them to come up with ideas on how to improve their environment and behavioral safety around their home. We're also encouraging visual medical screenings and assessing their medications. So a pharmacist will come in and review medications. And next week's webinar will be talking more in depth about these programs. The other one is Matter of Balance. This program, again, targets 60 plus independent ambulatory adults who can critical think. They're concerned about falling. They are interested in improving flexibility, balance, and strength. And both of these programs are very similar in the program contents. They're both about exercise and really just making a behavioral change with these people. In the Matter of Balance, they learn to view falls and fear of falling as controllable and setting realistic goals for increased activity, to change their environment to reduce fall risk factors, and we also want them to, we also promote exercise to increase strength and balance. And that's probably the most important thing to promote, is to increase that strength and balance, because that's going to keep them from falling. So when we're in, Stepping On uses a thing called preventive framework, and what it's done is it's reframed the decision-making model into 5 simple questions to assist group leaders in utilizing the model in practice. The questions are used as prompts in response to fall and safety stories to elicit reflection and discussion. We call these questions the preventive framework. So we have them kind of come up with the answers. We don't give them the answers. We have them kind of come up with the answers, and then the group helps them as well. Caregivers are huge. So we have the independent active adult, but we also have a lot of people who we've got to get the information to their caregivers who are now taking care of them, and the importance of preventing falls. Family members and other caregivers of older adults can help protect their loved ones and health and independence by talking about the health issues and risks for injuries. Fall prevention is the most important topic so that we can keep them independent and out of the nursing homes. Talk facts. Give them the facts about falls and make their environment safer. So what are some myths about older adult falls? Well, first one, I don't need to talk to my parent, spouse, or older adult if I'm concerned about their risk for falling. It will hurt their feelings and it's none of my business. But really, you need to let them know that you are concerned about them, you're willing to support them so that they can remain as independent as possible. And there are many things the caregiver can do, including removing hazards in the home, finding a fall prevention program in the community, or even setting up a vision exam. Another myth, I don't need to talk to my family members or my health care provider if I'm concerned about my risk of falling. I don't want to alarm them, and I want to keep my independence. Well, fall prevention, in fact, is a team effort, and we want them to bring it up with their doctor and family so we can help them. We want them to maintain their mobility and reduce their risk of falling. Many older adults are scared that if somebody gets called in to help them, they're going to be shipped right off to the nursing home, and that's not true. So when you're talking to a loved one or somebody that you're taking care of about providing their good, when you're talking about maybe taking care of them, you want the best of them, you want them to be independent, you really want to establish the right setting and the right time to initiate this talk. Schedule the talk when it's convenient for all family members. Get together where it's comfortable, quiet, and soothing. Maintain a level tone of voice, and really listen to what that person, that older adult, is saying. If there's tension, use humor, and definitely listen to the wants, needs, and concerns of the senior. You want to discuss each option openly and encourage both the senior and family members to have an open mind. Definitely remain calm and keep the discussion as enjoyable and positive as possible, and just know to walk away. Sometimes you'll just have to kind of set it aside and come back and address this conversation. Talk facts. A parent who has fallen is at risk for falls, or one who is afraid of falling may be reluctant to accept the need for help. So this is where family caregivers can step in and make a solid case to let them know that falls do happen. There are many options to prevent falls, and you want to keep them out of the hospital. You want to keep them independent as possible. So how are you going to help them make these changes? Well, emphasize the positive. What are they doing already to kind of reduce those risks for falls? Build on their strengths. Promote exercise. Teach that falls are preventable. Respect their independence. They have life lessons. They have stories. They've been there, done it. So you really want to listen to what they have to say. Use different methods of delivery and practice and assess for understanding. Are they understanding what you're telling them? Definitely, if you're taking care of an older adult, you want to check them every once in a while to make sure you don't see any bruising, limbs, or discomfort. A lot of times they won't let you know when they've had that fall, and it's very important to kind of keep an eye on them. Have regular discussions to see how they're doing, and let them know you can trust them. Older people may be reluctant to tell you about falls, and they may fear having to move into a nursing home. So what are some resources? Well, there's a fall prevention network, and the website's on the bottom of the screen here, but it's a free referral service that connects Denver Metro residents with trained professionals who can perform the following fall prevention services. So if you need help finding a physical activity program, or Volunteers of America is part of the network, and they can come in and help you make some modifications to your house. They can put you in touch with somebody who can review your medications, or somebody that maybe works with seniors and vision services. So it's a great network. They've screened everybody, and it's free. Other resources: Centers for Disease Control and Prevention, the CDC, area of agencies. So the area of agency for Colorado here, Denver Metro, is Dr. Cog. Aging and Adult Services has a website you can go to, and the Colorado area of agencies on aging as well. So there's lots of resources, and this will be available for you guys after the presentation. I believe they'll be sending this out. CDC has great posters and brochures. There's a checklist for safety and what you can do to prevent falls. But again, we really want to promote education and then other activities as well. Now I'm going to turn this over to Sally.
Hi, and I just wanted to interrupt real quick.
Okay, thanks, Tracy. While Tracy's switching that over, Erin, as the moderator, has a few comments.
Hi, I just wanted to let everybody know that you can submit questions at any time throughout the webinar. Questions will be answered during the Q&A session following all of the presentations. So please use the questions area of the webinar control panel to submit your questions at any time. Thank you.
Okay, this is Sally. We're just doing the switch to my presentation. And just to kind of get started with that as we switch to the slides, Tracy talked a lot about, you can see there's a lot of different parts of education, from what do we say once we get older adults in classes, in programs, as well as how caregivers can help with that. So what I wanted to do in my part of it was talk about just some results that I got from a program study that I was involved in, just some kind of public health thoughts from that program, and then also talk about some resources that I found about how older adults are thinking and learning that kind of dovetail with what Tracy was talking about. So I was involved in a clinical randomized control trial about how to work with churches to market balance and strength classes for older adult fall prevention. And the information about the study that we have to always put up with any slides is at the bottom there. So we were trying to figure out, we were testing how to use churches as a way to reach older adults. And there's a lot of different parts to the study, but I just wanted to talk about the fact that we use what I call the formal methods of education, which were, we had good brochures, we had good flyers and posters and announcements, that kind of thing. And we also had that more informal communication. That means going to coffee hour at churches. I went to a lot of churches, talked at coffee hour, talked at Bible study, and then also gave information to pastors, secretaries, that kind of thing, so that they could spread the word about these classes. And again, we had a lot of different results, but I just wanted to show you a few things that I think are really important for public health. This is the one about how did you hear about information that would lead you to choose to attend one of these classes. So in this case it was classes, but it could be anything that we're asking older adults to do. Well, what they heard really was that classes were available and balanced classes prevent falls. And I think that the other messages didn't seem to resonate because, frankly, they already know that. They know about falls. They're all concerned about falls. So this was the fact they joined up for classes when they found out, oh, they work and they're going to be available here. So that just reiterates making that message very direct and simple to what action you'd like them to take. And then how did you receive this information? And again, when all of us have probably been involved with making that perfect brochure, and we're going to increase awareness of older adults or what they should do, and then therefore they'll do it. Well, what motivated people to take classes was not the brochure or the poster, although that information was available at every single church. But what made the difference in choosing to take the class was conversation with a church member. Sometimes that was another older adult, or it could have been their family member who got the information. Or it was what the pastor said in a pulpit announcement or what they read about in a church bulletin. So again, remember that kind of the informal one-on-one contact makes a big difference in educating, particularly when you're giving solutions. So there are a couple of resources that I found I thought were really good to give kind of a background about how older adults think and how to develop materials for them. And I have the resources at the bottom, and you'll be able to see at the end where we'll be posting the presentation. But some things change with age, but other things don't. So of course there's changes in vision, there's a little slower processing of information, less working memory. That's just a memory you have to do all the things that are thrown at you at one time. So not as much multitasking ability, harder to focus on things and deal with distractions, and less flexible thought processes. That's just to, when there's a lot of information, how to change their judgments as you're giving them information, how to engage in divergent thinking or generating alternate explanations or solutions. So those things are really just get a little bit slower. But the things that don't really change are that extensive base of experience and decision making. And I know, for instance, with my dad, when I talked to him about using sailing as a metaphor for what he needed to do and make constant course corrections, that made more sense to him than talking about, you know, the medical condition and the weight gain and the congestive heart failure. That wasn't as easy for him to understand. Older adults we seem to be able to keep our ability to process the spoken word, assuming that you're able to hear that message clearly. So that's why often one-on-one conversations or talks are more effective than just giving them something to read. And we maintain the ability to look and interpret pictures and images. So that would lead me to think, oh, I need to be sure I'm using those kinds of pictures and images. So these are just things. There's more information in this material, background material, to get you thinking about how can you change the ways that you're dealing with older adults. And then it also leads us to the next idea about how older adults are going to make decisions. And, you know, there's advantages and disadvantages to this method, but older adults are probably going to review less information, eliminate choices or possibilities more quickly, less likely to analyze everything, maybe making decisions based on set rules like, I don't want to pay over $25 for any class, or I'm only going to do it if my doctor tells me to do it, that kind of thing. So giving people just a ton of information is probably not going to be helpful. And they use references to prior experiences really than looking at objective data. So while it's maybe really important for the family members to have all this information, it's also for the older adults very helpful to say, well, you know, when you made decisions about buying a house or something like that, how did you make that decision? So using their prior experiences rather than just saying, look at all this data and wouldn't you choose this solution based on all this data? So the one way is when we're developing any kinds of written materials is to make sure that we're using what we learn about older adults. And one thing I did want to mention is that obviously these are generalizations about people as they age, but some of this really doesn't come into be a big factor until people are, say, over 80. And people have quite a range of cognitive abilities, and as I get older, I'm hoping I'm in that category where things aren't going to really start to decrease until I'm, you know, 90 or 95. But just be aware that these are the things that do start to come up. So as you're writing written materials, and again, there are some good resources from all three of these slides, breaking the text into clear sections, so answering the questions that you've found out people really want to know, using lots of white space. But we found, I'll show you a slide later, that older adults sometimes have told us that, well, you're using too much empty space, you're wasting space, so be aware of that. Kind of the fonts that are readable, you know, at least 12, size 12 font. Don't try to cram information in. Something that's really good contrast, so anyone with low vision or vision problems can see that. And I'll show you an couple examples of what isn't really good, and go for really straightforward, not clever ideas. Older adults, sometimes the cognitive processing, they don't really get the kind of clever jokes that ad people want to use. They want just that straightforward, what are you really trying to tell us? And uncomplicated pictures and diagrams that really meet the needs of what you're trying to to show people. And this really works for everybody. But what you can find you can get a lot of good information from evaluating. You know, as you're developing your materials, test it with your older adult. So once you've developed those materials, continue to kind of test and see if does this information make sense? Did you use the information in the brochure? And then also, after you change your materials and you develop that new set of information, once you've introduced the materials, test again. So it's really important to work with older adults, and you can learn a lot. And I just wanted to show a couple examples. Our program to try and get the N-Balance classes in the churches, in the community. For example, the woman on the right, we had a different picture where the woman seemed to be meditating, and the picture, people didn't understand what she was doing, and they said, you have too much space, you should make use of that space better. So we enlarged the image. We also used images of men, so we alternate the images. We had Hispanic man as well, so we changed the images because older adults seem to really focus on, well, that's not me, and the images need to be them. So we also had some flyers. So while the brochure I thought was excellent, had a lot of information, and sometimes the people said, well, okay, I'm interested in the class, just tell me when it's going to be and what do I need to know, and we could use something like a flyer, again with somebody who's doing an activity that doesn't seem too far-fetched from what they might be able to do. And we had a lot of really clever bookmark ideas, but the bookmark ideas had text running up and down, running vertically, and in the small print it didn't really seem to be workable. So we tested some things and found out a bookmark that just had our symbol as a reminder and not a big message, but something that was a magnifying bookmark could be very helpful, particularly when we're talking about Bible studies. So we learned some things from testing the materials. And then just a couple examples from I worked on a project about pandemic flu preparedness, and I thought this was, you know, clever and interesting because a lot of the older adults had parents who were around in the 1918 flu epidemic, and so I thought the idea is this isn't how we prepare for pandemic flu now, and then that would pull you into the materials. But I found out this really tested very poorly. People felt insulted. They said, well, we know it's not like 1918. Tell us what we need to know now. And so that kind of clever twist really backfired in testing. And also everybody said, you know, I can't really read that print. So that's where you learn to use print that's easier to read. And so we use something like this, where we're getting that same kind of message across, but drawing people into a family scene, but with something a message they need to do in the background. And sometimes with images, you're unexpected what you can get when you test with the audience. We tested one message that was kind of similar to this, and some people we tested said, you know, that doesn't look like me. It looks like a bunch of rich white ladies, and that's not my group. And so they really were turned off by this image instead of those of us that proposed it thought it was a nice, engaging, social environment. And then another image where we wanted to show grandparents being active. People said, well, they don't really look like grandparents. They don't really look old enough. Are those their grandkids? Are they taking care of their grandkids? Are the grandkids living with them? So sometimes the older adults can get really drawn into the picture as a story and get distracted from what you're trying to do. So they also may say, well, I can't really get up and run in the park with my grandkids, so if that's what this program is about, it's not for me. So sometimes you really have to spend a lot of time picking right images, making sure that it represents everybody you're trying to reach, and also that it's really illustrating the direct story that you're trying to tell. And I found this on a CDC website that I really liked. Really the points we want to make in anything is we want a society where older adults can be independent, and while falls are a threat, especially when we're talking to other than older adults, since the older adults already know this, that there are opportunities to reduce falls and that there are interventions that are helpful. So I thought this was a much better idea for messages than we may use in other settings. And then see if my last slide will come up. It was just really talking about some of the CDC materials I think are really good and very engaging, very simple to read and very concrete. But the problem with them sometimes is that they deal with, this is what older adults should do. Older adults need to do this, and there aren't enough materials that talk about what we can do as a community to help with this. And that's actually, it looks like my last slide isn't coming up, but that was it. So I'm going to now change the presenter over to Kimberly.
Thanks, Sally. Can everyone see my screen okay? Hopefully it's up right now. Good afternoon. In addition to targeting educational older adults and caregivers, as Tracy and Sally mentioned, healthcare providers are another key audience to reach. I'm really going to be focusing on that for my portion of the presentation. Similar to caregivers, healthcare providers can be key influencers and change agents among older adults. And I think they really can carry a lot of weight and influence on older adults' perceptions, behaviors, especially as it pertains to their health. So why do healthcare providers need fall prevention education? According to a physician study we conducted here at Tri-County Health Department, only 8% of physicians surveyed based their recommendations on clinical guidelines. If you're not familiar with clinical guidelines, they're really topic-specific tools based on reliable scientific data to promote effective and efficient medical management. And it's mainly targeted toward providers that are providing clinical service. Most notably, the American Geriatric Society and British Geriatric Society have published fall prevention clinical guidelines. And I think what's really interesting is that the majority of the physicians that we surveyed, they did not use clinical guidelines when providing fall prevention recommendations to their patients. So annual fall screening of older adult patients is recommended by the AGS, or the American Geriatric Society. In Tri-County Health Department study, 88% of physicians reported experiencing some type of barrier to providing fall prevention screening. 53% reported lack of training as a barrier to screening for falls, and 65% reported lack of educational materials. Most physicians only reported screening patients who expressed concern about falls. And I think this is a significant piece because previous studies really indicate that patients are reluctant to voice concerns. And this goes back a little bit to what Tracy was saying. You know, there's denial, or an older adult is hesitant to label themselves at risk in the threat of independence. The study's conclusion as it relates to today's presentation is that many physicians lack awareness in addressing fall risk. The article from this study, which I'll reference later in the last slide so you can review it if you'd like, also suggests that some physicians required targeted interventions to improve fall prevention practices and use of clinical guidelines. It also suggests that providing physicians with training, screening guides, educational materials, home safety checklists, and referral sources are needed. Although the study specifically surveyed physicians, it's important to remember that all clinicians and non-clinicians within a practice have an important role in providing fall prevention interventions. It just happens that our particular study really focused on physician behavior and perceptions. So how do you go about educating providers? One strategy we're currently piloting as part of a CDC grant awarded to the State Health Department is called Clinician Engagement and Education Sessions. These sessions incorporate aspects of academic detailing, which probably most people are familiar with the pharmaceutical industry, and also Everett Rogers' diffusion of innovation theory to promote guidelines acceptance and practice changes. To implement these sessions, we're meeting with individual practices, specifically in Adams and Arapahoe County, and we're meeting with these practices typically over their lunch hour or when they have scheduled meetings. We start off by having them complete a set of forms to determine where the practice is currently at in addressing falls. And then we introduced new standards of care for fall prevention, which include guidelines, screening, assessment, and referral tools, and also patient education resources. Excuse me. We then present the practice's baseline information that we collected in step 1 to help them understand where they're currently at, and then we help the practice really identify where they want to be. So we're providing facilitated support for the practice to set their own goals. And we also continue to facilitate the practice to identify specific strategies so that they can integrate fall prevention into their daily workflows and interacting with their patients. At the conclusion of our sessions, we mentioned that we'll be following up with their practice after they've implemented changes and find out how it's working. So we have follow-up scheduled throughout the project, which is a 5-year grant, to really find out, if the strategies they identified is working and how everything's going for them. We're also piloting some tools that were developed by CDC when we're doing these sessions, and the tools are really developed to support primary care practices to integrate fall prevention components. The study toolkit, which stands for Stopping Elderly Accidents, Deaths, and Injuries, was developed by CDC to facilitate the inclusion of fall prevention into clinical practice. It's an evidence-based resource, and it was developed by CDC, but it was based on the AGS and BGS guidelines I mentioned earlier. There are a total of 10 different resources for providers. It includes a wall chart, a pocket guide for those members of the practice that want to carry around tools with them, fact sheets, flow charts for risk assessments and interventions, case studies to give them some examples of how practices have used some of these models, orthostatic blood pressure, other assessments for gait and balance, and a checklist and specific referral forms we're piloting in the Denver area to local resources. There are also 5 items for patient education. It includes a self-risk assessment brochure, a home safety brochure, postural hypotension brochure, as well as chair rise exercise handout, and the general falls prevention brochure. All of these resources are expected to become available to the public by the end of the year on CDC's website, and I will show that later to you in one of the slides. In addition to the study toolkit itself, CDC is planning on releasing a study implementation guide. This guide provides instructions specifically for healthcare providers to incorporate the study toolkit into their clinical practice. So it'll involve a lot of the components I mentioned earlier about how we're going to be working with clinical practice. But it provides information about the prevalence of falls and really healthcare providers' role in that. Provides some basic background information about how the study toolkit was developed, and then really how to facilitate and evaluate the adoption of study components in a clinical practice. There will also be an appendix with implementation materials, data collection instruments that we'll be using specifically in our project that will help us evaluate, and then also sample public relation materials if people want to be doing press releases around this issue. The implementation guide will also be made available, and I think at this point CDC is planning on releasing that sometime after we complete the pilot. So I'm thinking spring, summer of 2013. Once these resources are available, they will be posted on CDC's website, and I've listed that up top here on this slide. I've also included Everett Rogers' book if you want to learn more information about the diffusions of innovations that I mentioned earlier. And then I also included the article that references Tri-County Health Department's physician study. So I'm going to go ahead and turn it over to Tamara. She's going to introduce us to the next webinar series and open it up for questions.
Hi, everyone. I hope everyone enjoyed the second of the series of our webinars entitled Education Programs for Older Adults and Their Caregivers. Our next webinar will be on October the 15th. It will be entitled Progressive Exercise Programs to Improve Mobility, Strength, and Balance. The moderator will be Melissa Pruitt. She's the Community Falls Prevention Specialist and the Wellness Services Coordinator at Boulder County Area Agency on Aging. Just want to remind everyone that you need to register for each webinar. You don't just register for the whole series. So each webinar has to be done individually. I hope you've enjoyed it, and I think Erin will take over now, and she will get each of our speakers to answer your questions. Thanks, Erin.
All righty. So we have not had any questions come across during the webinar. So if you have any questions, ask them now. Just to let everyone know that this webinar has been recorded, and after a formatting process here, it will be posted to the Older Adult Falls Coalition website, which is www.olderadultfallscoalitionco.com, which was also on the previous screen. And I can actually unmute if you guys want to just ask questions over the phone. So if you don't wish to ask questions, I think you're able to mute yourself on your computer. Are there any questions? Alrighty, well, thank you all for joining us. I'd like to thank you for participating in the webinar. For more information, you can go to olderadultfallscoalitionco.com. Thank you, and have a great day.